All right. So we have a case of Ms. S. She's a 38-year-old woman, doesn't have any significant past medical history, and she presents to urgent care with a day of unilateral right calf swelling and tenderness after she had just gotten back from a 20-hour nonstop flight from Singapore back to New York City. She gets the lower extremity ultrasound that's consistent with the DVT. She tells you she doesn't take any medications. Her family history is significant for a DVT in her mother during pregnancy at age 34, as well as a DVT in her sister at the age of 42 that she believes was unprovoked. She doesn't really know the details or if any of them got testing for thrombophilia. She started on rivaroxaban, and you're seeing her now for follow-up in primary care clinic a week later. You're considering whether to test her for inherited or acquired forms of thrombophilia. So to start out with, wanted to ask you just in general how you go about taking a history from a patient such as this, in terms of the present history as well as family history.
This is an excellent case, and I actually do see these kinds of patients in my clinic all the time. And they can cause a lot of anxiety in someone who's young and has no other medical problems and hasn't been hospitalized. So I think you've hit some of the highlights in this patient's history, right? We look for, first of all, the personal history of thrombosis, whether they've not only had thrombosis themselves in the past, but also whether they've had any challenges. Right? So did they have their appendix out? Did they break their leg and were they in a cast? Did they take oral contraceptives? All of those factors in a young woman would be challenges for risk of thrombosis, as well as pregnancy. So pregnancy and oral contraceptive use are things that we ask. And then, as nicely obtained in this patient's family history, we ask not only has anyone in the family had thrombosis, but at what age have they had thrombosis, right? So like grandpa with prostate cancer at age 76 having a PE is not the kind of history we're looking for. We're looking for people who've had thrombotic events primarily under the age of 50, because that's where you get concerned that the threshold for getting a clot is lower. It takes more to have a clot when you're under the age of 50 than when you're over the age of 50. And so that's why age is such an important factor. And again, as you point out, what's going on? So her mother had a clot during pregnancy. Pregnancy is one of the highest risk states for women for developing VTE. And so those are all important factors. Seasoned coagulation experts can tell a patient based on their family history what the likelihood is of having a thrombophilia, because I see a lot of patients who have sort of a number of environmental factors that all collide and cause the perfect storm to have a clot, and they have no family history. Those patients, it's very unlikely that you're going to get a clot. But here we have a clear family history in 2 first-degree relatives, right? So the mother and the sister. The second-degree relatives are less concerning to us, So Uncle John's daughter is not somebody that we really care about whether or not they had a VTE.
Yeah, this is, I find that this topic, and we're going to get into this, of course, but it's just we were talking about this beforehand. It's just like, even if we do identify, it's still confusing, but it's good to know. I think it's very good information that age less than 50 and that you're saying first degree. So that's like siblings or parents. Those are the ones that we care about most. And so even like grandparents, aunts and uncles, that's less.
It's less compelling, right? Mm-hmm. I mean, we really look at the first degree family members. One of the reasons that age is not so concerning, age at the event, right? So again, it's not that grandpa was 76 when, or is 76 now, but that he had his clot at age 76, right? If he had a clot at age 40, you might be a little more concerned. And inflammation actually drives up risk for thrombosis in older patients. And there's a great manuscript in hematology in 2007 that you can just look at the curve and then it hits 60 and it goes up very sort of non-linearly. It's fascinating. So that's why we know that people who have clots under the age of 50, there is some other factor besides the, say, a provoking factor in this patient who had a 20-hour flight, right? That makes it easier for them to develop a clot than other people their age. But the age, and also too the type of thrombosis. Again, I get a lot of patients who say, "Well, my grandmother had a stroke, right?" And so again, a stroke at age 67 is not the same as the father had a PE at age 42. And sometimes I do ask, well, what was the setting? Well, my father had reconstruction surgery at age 42. And so you kind of get a sense of factors that contributed.
In terms of weighting of the different risk factors and the way that you think about them, do you have a framework to say, it sounds like first-degree relatives and that family history is obviously kind of quite high in terms of thinking about thrombophilia, but other risk factors and parts of the history that make you think about the likelihood of thrombophilia?
Well, again, I think, as I've sort of been hinting at age, right? Age is a huge component. The younger you are, the stronger the factor has to be to cause a clot. And so if you're already, we know that inherited thrombophilias lower the threshold at which you develop a clot, right? So two people sitting on a plane from Singapore for 20 hours, right? One has an inherited thrombophilia. That bar for that, the stimulus for them to get a clot is lower than someone who doesn't have an inherited thrombophilia. And so that's kind of how we look at it. And these factors are all sort of synergistic too. And I could go on about what we consider strong risk factors versus moderate versus weak, and where the field has sort of fallen out on some of these. For example, major abdominal pelvic surgery or joint surgery is much more prothrombotic in neurosurgery than, say, having a mole removed, right? Or a lower extremity fracture and casting and immobilization, much more concerning than like breaking your elbow. So those are the types of factors we look at with regard to major provoking factors. Flight and air travel is one which is fascinating. We all sort of in the coag world think, most of us think that there's definitely a contributing factor. In the past, it was considered just a weak factor alone. And so, the people look for other things, including inherited thrombophilia. I tend to firmly believe in that and do think it is a significant factor. And I take that seriously. Another factor is estrogens. So again, as I've alluded to, pregnancy is one of the highest prothrombotic states, particularly the first 6 weeks after delivery. That's amplified by C-section, but also oral contraceptives. And I just gave a presentation actually to the hematology and obstetrics group in New Zealand last Friday night in Australia about the risk of hormonal treatments and thrombosis. And we forget, we prescribe millions of birth control pill prescriptions per year, but the odds ratio of having thrombosis is about 3.5 for a woman compared to no hormonal contraceptives at all. So something to keep in mind when you're talking to your patients.
Is that true of estrogen replacement therapy and also IVF-related hormones?
So those are great questions, right? The type of estrogen matters. So the type of estrogens we use for combination oral contraceptives, ethinyl estradiol plus a progestin agent, is very different from what we use for menopausal, postmenopausal hormone replacement, which is estradiol or E2. And so the dosing, the formulation, and the risks are very, very different. They're much higher with ethinyl estradiol than they are with the estradiol formulation itself.
All right. Well, we want to try to figure out who we should test. Molly, I think you have a bunch of, well, first of all, this woman that we gave you here, this is a 38-year-old. She has this family history, and we've diagnosed a clot in her. Is she somebody that we should think about testing as the primary care that's seeing her in follow-up?
So that, as you probably are aware, is a very controversial topic,
Sure.
right? And I wrote a review 2017, published in New England Journal.
Yes,
and
amazing.
People
Yeah.
read that and say, "Oh, Jean, I know you never test people," and that's not actually true. What you need to know is, why are you testing this person, and what are you going to do with the results? Because I have seen so many people, they've had like their gallbladder out and they get a DVT or a PE, and then someone tests them, and it might make sense. Maybe she's a 42-year-old woman and, had her gallbladder out, and they find heterozygous factor V Leiden, and then they put that patient on anticoagulation like forever, right? And that is not indicated in those situations. So although having an inherited thrombophilia decreases your threshold for getting a clot, it doesn't appear to increase your risk of a recurrence. As I like to say, as long as when that patient encounters other, high risk situations, that they get appropriate prophylaxis. So I think I would test this woman for a couple of different reasons, right? She probably wants to know why she got a thrombosis. She has 2 family members, including a sister, who might benefit from knowing. I will tell you that I have found that if you label someone as having an inherited thrombophilia, surgical specialties tend to take a little more notice of the patient's risk for thrombosis, and reach out and ask about perioperative prophylaxis. And I think our surgeons are so much more aware of thrombotic risk now than they were even 10 years ago. But when you've got someone who carries that diagnosis, then it flags it for everyone's attention. The converse is that we know that in patients, so say this person has factor V Leiden, is heterozygous, and you test her and you tell her, and then her mother goes and gets tested, and her mother's heterozygous for factor V Leiden. So her sister goes and gets tested, but her sister's not. We know that sister still has probably a higher risk of thrombosis than someone whose family does not have factor V Leiden, because factor V Leiden doesn't act the same from family to family. And so we think there are other modifiers that are either genetic or environmental that no one's been able to identify. And it seems to have more penetrance, if you will, in some families than others. So that's one of the caveats of testing, and one of the downfalls. Just because you're negative doesn't mean you don't have the risk.